pathologist here at West Coast General Hospital. I just started in March of this year, and actually at this site in April 2025. I've been a speech pathologist for about 3 years now, mostly in acute care and emerge and ICU, so exclusively with adults. I'm very excited to be at this site. I know it's a new service for West Coast, so I'm excited to be part of the team and chat with you a little bit about how I fit into the medical picture and what my role is, because I know that can be very confusing for people, not just at this site, but at all sites. So hopefully I can preemptively answer some questions that may have come up. I have my PowerPoint here. Okay, so a roadmap for what I am hoping to tell you about in the next 20 minutes is really the who, what, and when of my role. So the types of patients that I see, what it is I'm actually doing with those patients, and how it's different from a dietitian, because I know that question comes up a lot. And then we'll talk a little bit about communication especially, and some of the less obvious reasons that you might want to refer to me or ways I can help. But since this is primarily an acute care site, I'll focus more on the swallowing side of things. So scope of practice of an SLP is quite large. It encompasses all of these things and more. But broadly, our role is to diagnose, assess, and treat issues with swallowing or communication disorders. So those two umbrellas. Up here on the screen, we've got some of the most common patients that I see, or groups of patients that I see. I like the Venn diagram because it makes it very obvious that for a lot of these neuro folks especially, they're going to have both swallowing and communication needs. Two very different functions, but it's often all the same or quite similar anatomy. So we're just applying our knowledge of that anatomy and physiology to speech and swallowing. Different functions, but same thing. Especially some of those ones in the middle, it's very important that these people are on an SLP's radar, especially in terms of the neurodegeneration folks. These are people who are a lot easier to treat preemptively. It's a lot easier to maintain voice and swallowing than it is to fix it once they're further down that path. So if you come across these folks and they don't have any SLP involvement, good idea to put them on my radar. Maybe I'll put you on the spot, Dallas, and ask you,
okay.
What do you think is my primary goal when it comes to treating dysphagia?
Making sure that the patients don't develop a pneumonia, and that staff members are following the precautions for swallowing, just making sure that they're not using the thin fluids and that they're using the thickened fluids that you suggest.
Okay.
Right,
yep.
track.
all answers I have heard before. That is the typical idea that people have about SLP. Really, it's B.
B, okay.
Yeah,
okay.
We want to optimize health and quality of life related to nutrition and hydration. And if you are confused about, or even more confused about how is this different than a dietitian, that is okay. Thickened fluids, as a bit of an aside, I will avoid thickening fluids if at all possible.
Okay.
Because it can have some pretty negative ramifications for your patients in terms of dehydration, in terms of medication absorption, and if they are aspirated, they are actually more dangerous
Okay.
than fluids. So I know we all thicken occasionally at bedside, but it is not a one-to-one that thicker is safer. So
This is great information.
proceed with caution.
Okay.
And you are partially correct that we want to minimize the risk of pneumonia. We want to flag those patients who are at risk of developing a pneumonia. But our role isn't necessarily to prevent aspiration, because aspiration, for one, is inevitable. I cannot prevent it entirely. And it's also not inherently problematic.
Right.
So every single one of your patients aspirates on a daily basis. All of us as humans aspirate on a daily basis. Very small amounts of saliva, we don't notice it, but it is a healthy body function that's required to maintain your lung microbiome. So it's not necessarily a problem until people start aspirating large volumes of food or liquid. And even then, it isn't always going to be a problem for that patient. It's not always going to lead to a pneumonia. So that is where the SLP comes in.
All right.
This is definitely what I look like when I'm trying to explain swallowing to people. There are a lot of factors that go into a risk assessment of why aspiration may or may not be a problem for a particular patient. And when I go to see your patients at bedside, I'll do a swallow evaluation, but I'm also doing a really comprehensive look at their medical history, looking at their labs and looking at their chest imaging, and weighing all of these things together to determine how high risk is this person? Is this something that we necessarily need to treat? Do we need to modify their diet? Can they stay on a regular diet? And I might have very different recommendations for two patients who, from a dysphagia standpoint, are very similar. So we can be useful in that sense, giving you an idea of risk. Okay, dietitians and speech pathologists, lots of overlap. They are wonderful to work with, and especially at this site, I know Chelsea has really stepped up in the past few years doing a lot of swallow assessments. She's done really well at it. But it's not really the dietitian's job to manage dysphagia. They can identify that it's there, that this person is perhaps coughing and sputtering with fluids. They may be aspirating. They acknowledge that there's this risk of aspiration, and that is sort of where their role ends. And then they refer on to SLP. In acute care, it's a lot easier to just refer straight to the SLP. Because we are the ones who will say, okay, yes, this person seems like they're probably aspirating. We'll confirm it with further studies, and we'll figure out the biomechanical reason for it. Why is this person aspirating? Swallowing is a very, very complex function. It involves over 30 muscles and cranial nerves. It gets really complicated really fast. So we need to figure out exactly why and what has gone wrong with the swallow in order to then treat it. That's the primary difference, is that we can take those next steps in the assessment and treatment process. Dietitians will definitely have a role in modifying diets as well. So there's a bit of overlap there. I don't care if someone is eating a donut or an apple. That doesn't make a difference to me. That's the dietitian's domain to figure out how we're going to optimize those individual items, make sure the person is getting the proper nutrition, they're getting enough protein, carbohydrates. My role is more from a texture standpoint of, does this food present a choking hazard to the patient? Does it present an aspiration hazard to the patient? And are they going to be able to chew it and swallow it comfortably. Okay. So these are two of the tests that we do as SLPs when we're looking at someone swallowing. Up on the left is a VFSS, so video fluoroscopic swallow study. I do this twice a week normally at this site with both inpatients and outpatients. We sit them in front of the x-ray, we give them food and drink that has barium, and we watch and see what's moving, what isn't. Is the airway closing? Are they swallowing on time? And where is that contrast going? So for this person, they're having a little bit of airway invasion, you can see towards the front, probably to the level of the vocal folds. On the right is another type of test that we can do. This is called a FEES, so fiber optic endoscopic evaluation of swallowing. We stick a very small camera on the end of a scope in through the nose, dangle it above the pharynx, and then we have this patient either speak if we're assessing their voice, or swallow different foods if we're assessing their swallowing. We can, again, see what's moving, what isn't. This is a good way to pick up on any structural issues that we might need to refer on to ENT for. And we can see how much residue gets left over in the throat. So this person will have had some possibly applesauce with green food dye, and after the swallow, it is not gone from their throat. So this might be a bit more of a problem for someone as they're eating solid foods or very sticky foods. And then once we have identified what is going wrong with the swallow, the goal is to manage that dysphagia as best we can. In the acute setting, most of the time this involves compensating for the impairment. So diet modification is always our first line of defense to try and optimize the food, minimize the risk that a patient is going to choke or aspirate. Because while they are acutely ill, they're obviously at a little bit higher risk than maybe someone in community. Sometimes I will put mealtime strategies, or I'll recommend specific postural maneuvers for patients. If you've ever seen one of the head of bed signs of mine that I put up, usually I'm putting one or two things, and they're not just arbitrary. They're selected for those patients based on what their physiology is, or what I am suspecting that it is based on a bedside assessment. So that might be something like getting someone to tuck their chin when they swallow liquid. Doesn't work for everybody. For some people it makes their swallowing worse, but that's why we do these tests, to figure that out. And then I also work with folks to try and rehabilitate the swallow. I don't want to identify a severe dysphagia, put someone on a puree diet, and then say good luck. Ideally, we are treating it. We're coming up with a plan of care or an exercise program to strengthen whatever weakness there is. A lot of the times this might be respiratory strength training, so that when things go down the wrong way, people can cough them back up more effectively. And for some people, it's things like strengthening those suprahyoid muscles to get more airway closure, strengthening the base of the tongue so that we're getting more propulsion through the pharynx, things like that. But again, it's very dependent on the individual patient. And we can't recommend any of these things without an instrumental first, unfortunately. Okay, switching gears to the communication side of things. This in acute care, I'm doing mostly with people who have strokes, or people who have Parkinson's, ALS, PSP, things like that. I don't typically see people for stuttering, but that is something that SLPs do in community. I also don't typically treat voice disorders in acute care, but that's something that I might flag as needing follow-up on an outpatient basis. I can also help with people coming into hospital who have AAC needs, so augmentative and assistive communication. And this basically just means any form of communication that doesn't involve speech. So everything from gestures to picture supports. We've got pain scales or basic communication needs. I can send you the copies of these if you need them. These sorts of things can come in very handy when you're communicating with folks who have aphasia, or people who have dementia as well. Sometimes they need that little extra visual support in order to understand what you're saying, or to help them get their message across and be making those choices for themselves. So those are the really low-tech options, but I can also help with people who come into hospital who are maybe using some more high-tech devices. So you might come across someone with ALS, for example, who's using an eye gaze communication system if they no longer have their voice or use of their hands. I can help people get set up with voice banking if they are losing their voice. We can start preemptively making recordings of their voice so that they can have that communication system later on in life, and they're not sounding very robotic like Stephen Hawking. They're sounding a bit more like themselves. That can be very comforting for people. Some less obvious roles in communication that you may not have thought of referring to an SLP for, and I know historically you haven't had an SLP to refer to for these, but these are scenarios that I have been involved in over the years, at least once for each one. And this involves mostly supportive communication strategies. Sometimes this is navigating really difficult conversations with patients about where they're going to be discharged to, or whether or not they want to move towards palliative measures, things like MAID. I've been involved in communication assessments for the purpose of determining whether someone with aphasia could reliably understand the questions they needed to, and reliably answer yes, no, or provide consent for MAID. This is maybe less relevant to nursing staff, but it's a way that I can collaborate with social work, with physicians, geriatricians in particular, if there are questions about someone's competency, especially with aphasia. Because I have seen far too many times people with aphasia being referred to as confused or cognitively impaired, and then an SLP comes on board, does their assessment, and realizes that actually they're cognitively intact, they just have no way of communicating that to us. So if you suspect that there is someone on your caseload who might fit that description, or you're just trying to make sure that you are optimizing your communication, don't hesitate to refer. I'm happy to help out with those things. Here's my contact information if you need to contact me, or just track me down in the hallway.
All right, I think Shelby, you did a wonderful job explaining this to everybody, and thank you very much for your time today.
Thank you.
All right.
Appreciate it.
Okay, thanks.